Good morning, and welcome to this session to discuss Academy Health's Paradigm Project. I'm Sherry Gleed, and along with Risa Lavizo-Murray, I co-chair the steering council that is guiding this effort. The Paradigm Project, which is funded by the Robert Wood Johnson Foundation, is an initiative to address the long-standing concern that our field could do more to assure that health policymakers and healthcare leaders have timely, relevant evidence to inform decision-making. What makes the Paradigm Project exciting and innovative, though, isn't just what we're trying to do, it's how. We're using the principles of human-centered design to ideate and test new approaches to the production, communication, and use of health services research. This morning, I'm going to provide a very brief overview of the project, and then Risa is going to moderate a discussion among 3 volunteers working closely with it. We hope that this session will give you a better idea of what Academy Health and RWJF are doing and how you can be involved. In the few minutes I have, I'm going to tell you a little more about the challenges the Paradigm Project is addressing. I'll also share some more about the modifications that we have made in light of both COVID-19 and the urgent need to address structural racism and its impacts on individuals, on public health, and on healthcare systems. Lisa Simpson, Academy Health CEO, has also shared some remarks about the Paradigm Project, which you can hear at the conference's virtual lobby. For the purposes of our project, we've organized the challenges facing health services research into 6 categories. The categories are, first, the sense of shared identity and purpose among health services researchers. Second, the questions that researchers ask. Third, who's involved in the health services research project. Fourth, data and methods. Fifth, how research findings are translated, communicated, and implemented. And 6th, the incentives embedded in the research enterprise. Each of these 6 can, of course, be further broken down into several component interrelated parts. To address these many, many challenges, Academy Health recruited a diverse group of about 100 professionals from all stages of their careers and from within and beyond the field of health services research. These volunteers help break down the components of these challenges into 17 interrelated parts. We then formed design teams of 4 to 6 individuals, and those teams have been working on each of the 17 challenges. The process we're using here is what is referred to as human-centered design, or design thinking. Human-centered design comes from the world of visual and consumer product design, and it relies on experimentation, which is to say, repeated iterations of testing and refinement to develop a solution that works for those who need it. A bias towards action, so that the end result of this project isn't just another written report. The product will be one or more ideas that we will actually prototype and test. And finally, the radical collaboration of diverse perspectives to generate truly out-of-the-box thinking. Our panelists today will give you a better sense of what it has been like to actually use these tools. The teams have made tremendous progress in their first year and a half, and we'd originally planned to share that progress with you at this meeting. You can still see it and learn more about what each team has done in the poster hall, where each of the teams is presenting its work today. But the COVID-19 pandemic and renewed public attention to the persistent and worsening impacts of systemic racism on health and healthcare have led us to refocus our work in new directions, and we actually want to use our time today to outline that shift. These recent developments, COVID-19 and the focus on structural racism, each illustrate in different ways the limitations of our current research paradigm and actually the importance of this project, which is revisiting that paradigm. Our goals, thus, could not be more essential. We have to make quicker progress towards more relevant, more responsive, more useful, accessible, and representative health services research and health policy. But at the same time that the relevance of our task has become ever more important, additional demands have been placed on our individual, organizational, and collective resources, which are largely volunteered. Design team members have personal and professional commitments that impact their time and focus on the project. There are significant and growing economic stressors in many organizations and communities. And the personal stress and mental health impacts of the pandemic, of racism and violence are real. To respond to all of those considerations and this moment, Academy Health has chosen to focus its resources and effort to quickly drive the most promising ideas towards real-world tests and to provide consistent thought leadership to guide the field. In the near term, Academy Health staff and its design consultants will work intensively with a subset of promising design teams working on challenges that are particularly relevant to what we have seen in this past year. Academy Health is also refocusing a portion of the project team's efforts to directly address high priority issues that have not been fully addressed by design team efforts so far. These include issues directly relevant to the field's ability to address systemic racism in its ranks and in its research, such as issues of promotion and tenure and of data quality and data use. We will do this by expert meetings and collaborations with the existing resources of Academy Health Education Council, Methods and Data Council, and with relevant member-led Academy Health interest groups. Finally, the staff will author or commission environmental scans and engage in thought leadership to broadly educate the design teams and the broader HSR community about the priority issues the Paradigm Project seeks to address and to create momentum for change. This is a very high-level overview, and I invite you to find more details and follow our progress on the project's webpage, www.academyhealth.org/Paradigm Project. At that page, I also invite you to be part of our reactor panel, the group we are using to assure that the design teams have the stakeholder input that they need. Now I'm going to turn the mic over to Risa to moderate our panel. Thank you.
Great. Thank you, Sherry. And I'd like to introduce our panel, Andy Beinman, Alfie Breland-Noble, and Pierre Vigilance. Welcome. And I would like to just start with the simple question of, can you just tell us a little bit about the challenge that your team faced in focusing on this Paradigm Project? Andy, do you want to start?
On the Paradigm Project, the group that I've been a part of has focused on a health services research training model and whether it's meeting the needs of potential trainees. Our group recognized, and I think the broader group recognized, that there's individuals who have interest in health services research who really want to use health services research to be change agents. But their approach to being change agents isn't necessarily through publishing research as the process, that they see other ways of trying to use health services research as a change tool. And so our group is really thinking about the need to support those to learn the skills of health services research who either want to pursue their activities in non-traditional academic roles or in roles outside of academia. And I would say that through a lot of the work that we'll get into describing, I think, as part of this panel, our group identified really a need for focusing on experiential learning at the center of the training model, and really thought about the essence of what the current training model looks like and the need to make experiential learning a more central part of that. The idea being that we would teach skills to trainees as they become relevant in the context of active engagement between a trainee and end users who could benefit from the research work. This isn't dissimilar from what's happening in many medical schools where the curriculum has been changed to expose students at a much earlier stage to clinical care, so that as they're learning about medical concepts, that they're able to apply them in the context of understanding clinical care. And so we did feel that this kind of experiential learning would not only help non-traditional academics and those working outside of academia, but even those who are traditional health services researchers, to develop more meaningful ways of developing questions, because by working with end users, the thought is that the questions that were most important come to the forefront. The other thing I'll say just before turning it over to my other panelists is that our group also raised questions about the name health services researchers and wondered to some extent whether the incorporation of the word research into our field can sometimes be off-putting for some end users who might be thinking about that as kind of experimentation as opposed to applying rigorous scientific skills. And many of the people that I think we're training maybe have more of a bent toward thinking themselves as applied problem solvers, maybe more the way engineers are than researchers are in some cases. So anyway, those are just some of the ideas that our group tackled with, really thinking about the training model and how it applied to our field in general.
Great. Thank you, Andy. Alfie, would you tell us about your group, please?
Sure. So our group is focused under, I think, two foci under one label. The label would be diversity, equity, inclusion, and belonging. I would say that that's overarching for our work. And within that, we're really focused on two groups. One is diversifying the voices, the lived experience, and the people who show up at the table in the development of health services research, Secondly is the diversification of people, I like to say phenotypes, lived experience of the people who co-lead research. And part of why we say co-lead in our group is because ultimately what we'd really like is to ensure that the end users for the kind of work that we produce, i.e. anybody who's ever been a patient, a payer, an investigator or an engineer, I'm gonna use my colleagues' terminology, or anything of that nature who has a stake in the game of health services research. We want those people to feel welcome and included and feel that they belong, because traditionally, I say this as a woman of color, health services research in some academic medical centers has not been the most welcoming of people who are not part of academia, one, and in particular, people who come from racially ethnic diverse backgrounds. I would say probably for LGBTQ queer folks as well. And so our goal is really to understand better what are the lived experiences of people within and under this umbrella of health services research, and then to build our prototype around how do we uplift and focus on those institutions and settings, right? It doesn't have to just be academic institutions, but those settings where people are actually getting it right. And so I think this was something that came to us before we found ourselves in the dual pandemics of systemic racism, discrimination, and COVID-19. And it's just taken on a greater sense of urgency because there's so much synergy. And for one, the synergy around health disparities and which communities are being most negatively impacted under COVID, as well as which communities are being most heavily negatively impacted due to systemic racism and discrimination. So that's our prototype. That's the topic area that we're focused on. And the group actually met recently and had an important conversation around how do we continue to move this work forward, knowing the great sense of urgency that we're under right now to really try to address these issues of systemic racism and healthcare for all.
Great. Thank you, Alfie. And Pierre, would you tell us a little bit about your group's focus?
Sure. Our group's focus was on data and methods in health services research uses, or the data and methods that it uses, primarily to get an understanding of how and why it is that qualitative research isn't given the same platform frequently that quantitative research is. So early in its history, health services research drew primarily from, economics, biosciences, and other disciplines where quantitative analysis and tightly controlled study designs predominated. In addition, traditional health services research typically values accuracy and rigor over timeliness of results to inform decision making. And my group was particularly concerned about those elements of things as well. If research is going to be done, it should be done in a way that's actionable, and it is done in a manner that is timely with respect to applications that can be used. So health service research typically and the researchers may not be familiar with, or may actually be averse to, using more iterative or adaptive methods that they are, first of all, not familiar with, such as qualitative research. And that can provide insights that give service providers better understanding of people's experiences within the context of, say, a care setting or a community in which they're in, which, as my colleagues just mentioned, Dr. Breland Noble just mentioned, is very timely right now, especially given the challenges that we are facing with COVID and some of the challenges that are being highlighted with respect to disparities in health and health outcomes. And so we were looking to, and I love our how might we question, which is how might we break the intergenerational cycle of privilege in quantitative methods? Because those methods that have typically been used by researchers to highlight the different elements of work that they're doing. They have been used for promotion and tenure procedures, as was mentioned before by Dr. Binman, and they have been things that have been really skewed towards essentially in the academic sector. And it's interesting because a lot of the work that I do, it really does require us to engage more in the understanding of people's lived experiences in a qualitative method and way, as opposed to the quantitative methods that are typically highlighted in sort of academic schemes. And so some of the questions that we were asking sort of related to or pointed to the fact that, conservative academic culture typically undervalues qualitative and other emerging methods, that incentives push young researchers to focus more on quantitative methods rather than qualitative, and that there is a discomfort when dealing with people from other disciplines and settings, which is another reason why it may be, quote unquote, easier to use quantitative methods than qualitative ones. And I think that many of these questions ended up falling under the similar umbrella to what Dr. Breeland-Noble was just talking about with respect to its impact on diversity and inclusion, its impact on the equity lens that we say that we use or want to use in health and healthcare and public health research, but don't always necessarily employ because we're not as comfortable with the methods that actually have us use that particular lens. And so this is really an interesting opportunity to have a team that was made up of people from industry, who are global health folks, people who are from the economic side of things, from schools of business, as well as folks from a couple schools of public health, as well as a couple community organization people to sort of come together and talk about this particular issue as it related to the data and methods that health services research uses.
Great. Well, thank you, Pierre. Both Alfie and Pierre have touched on the events that we're living through today and how those might affect health services research. But let me just very pointedly ask you all to reflect on how the events of the day, COVID, the reawakening, if you will, of the impacts of structural racism on health and beyond, to help us address what some of the challenges are that are facing health services research and potential for the Paradigm Project to shift things and make a difference. We, of course, began this before these events overtook us, but now I think we have a new urgency to address it directly. So maybe, Alfie, I'll start with you.
Sure. So for me, part of it is the heartbreak and disappointment of recognizing that there have been many of us who've been health disparities researchers for years, even within the health services field, who have tried to sound the alarm about these kinds of things. Maybe not necessarily COVID. I don't know that any of us could have predicted that, although some people did. Let's say that. Let me say that clearly. There's some scientists who clearly did say this is a possibility. But for those of us who do disparities research, everything that we're seeing now in terms of who has access to care, in terms of who's the most vulnerable, in terms of, I think a lot about watching Dr. Fauci describe a couple weeks ago, the conversation on which racial ethnic groups were most vulnerable, and not, and wanting so badly to say it's not just about the people's race and ethnicity and genetic makeup. It's really about these societal factors that we have not dealt with that contribute to placing people in harm's way disproportionately. So, that's not something that we didn't know. That's not something that we could not have known. That's something I feel like was a known entity, was a known quantity. But I do feel like because we have failed to place a strong emphasis on the needs of racially diverse populations, period. Health services researchers know this puts us in a position where, there are a lot of us who are kind of shaking our heads like, yeah, we kind of knew this was coming. And I think a lot about the people who very early on said we need to see the racial breakdown of the data of the cases. Show us the data. And people kept clamoring for it. And then, of course, once we got the data, what did we see? This disproportionate negative impact on people of Black descent, the African diaspora, and Latinx people, right? Because of all these things under this umbrella of social determinants of health. So for me, this is an opportunity for health services research to step up and be at the forefront and really lean on and look to those folks who are disparities researchers and build upon all of this knowledge that already exists. We don't really need new knowledge to talk about how to dismantle and disrupt some of the problems that the pandemic has shown us about disparities. But we have an opportunity as services researchers to really try to make a difference. So that's what my hope is.
Great, and maybe I'll turn to you, Andy, since you talked about the term health services research and whether other terms that emphasize the solutions in finding solutions might be more applicable. What do you see as the challenges and the potential of the Paradigm Project in today's environment?
Yeah, well, I mean, I would say, Risa, the stakes for health services research have never been higher with this worldwide, pandemic. Health services research has amazing frameworks for considering trade-off conflicts that can come up between access, cost, and quality, and also for assessing things like effectiveness, efficiency, and equity in how healthcare is delivered. Having said that, I have wondered during these last few months whether health services researchers will primarily end up contributing to describing the history of this pandemic, or will in fact play a central role in identifying and addressing key issues in their health systems and their communities. Can we contribute? Is our field ready to contribute to what is to come? Or are we really mostly focused on describing what has been? And are we critical or an afterthought in terms of working toward these solutions? I think we have tremendous things to offer, but perhaps had we different relationships with end users prior to this pandemic and made that a focus of our work, we might be in a better position to contribute to solutions and not simply be those in a role of describing. I think, to quote a famous line from a musical, I think health services researchers want to be in the room where it happens. And I think to be in the room where it happens requires investing time in building relationships with those in operational decision-making roles in policy and health systems and so forth. And I think that's when our skills have a real ability to shine and make a difference.
Yeah, I couldn't agree more. And it also means a timeliness and a willing to use different methods as you, Pierre, were pointing out. So anything you want to add on this topic, Pierre?
The only thing I'd add, and I appreciate my colleagues' comments on this, is that as much as we talk about this as being related to research and users, it's about us. It's about our interactions with each other as much as it is our interactions with people, communities, data sets, etc. If we cannot find it within our own selves to be able to honestly and authentically and transparently communicate and learn from each other within our teams, within our institutions, etc., then there is little hope that we'll be able to authentically and appropriately do so with users, consumers, patients, whatever we want to call the groups that we are talking with and designing with. And I think that that's something that is often also lost. I had a couple, unfortunately, heart-wrenching conversations with researchers talking about their own experiences as people trying to promote or move through their careers and finding that the institutions they were in were not supportive of the types of research they were doing, or that they were unable to get students to engage with them because of the kinds of work that they were doing, work that was near and dear to them and near and dear to their communities. So as much as we talk about this as being given the current light that's being turned on, my concern is, and my prayer is, that the lights stay on and that we don't choose to close the door on that particular room and go back to business as usual because that's the room in the house that we don't have to go in all the time. We have to turn the lights on in all the rooms and understand and be clear. And what I love about this project is that we made use of a methodology that speaks to and uses narrative and history. And the combination of those two things are things that are hard to run away from. And we collectively need to stop running.
Great. Well, that's a great segue into talking a little bit more about the methods that we've been using, human-centered design, and what your experiences have been with that methodology, maybe a little bit about what kinds of reactions you've had to it, because I think it does speak to a different way of understanding the work, as you pointed out, Pierre. So maybe, Alfie, I'll turn to you.
Sure. So what I remember distinctly is part of our methodology was sitting together and literally creating, one of our ideas was an award. And so everyone took pipe cleaners, multicolored pipe cleaners, construction paper, some other things, glue sticks, and we actually made an award. And it was enlightening for many reasons. One, because my artistic skills are horrendous. I went to the right field because I'm not an artist. But two, and more importantly, because it really gave us an opportunity as a team, the group that I work with, to have conversations about what did we want to sort of infuse the award with? Like, what was the meaning behind the award? Why would the award be important to someone? What would be something that would motivate someone to want to compete for this award? And our award was really around this idea of, going back to my colleague, Dr. Pierre's comment about our statement, like the mission statement, sort of. And so for us, it was really about how do we, as I said earlier, uplift those organizations and entities that are getting it right. And so the award, one person came up with something that kind of looked like an Academy Award. And we were all just like really excited about that, because the idea is you're trying to reward excellence. So for me, that part was very enlightening. It was wonderful to hear the stories of the team members as they talked through what the triumphs were in different workplaces they'd had where people were getting it right. By the same token, the struggle, one of the big struggles was, one of my ideas was, let's get people to, let's be creative, as Dr. Pierre said, let's be creative in terms of how we collect data. And so one of my ideas was, well, why don't we get people, it wasn't just my idea, but one of the ideas the group came up with was, why don't we get people to share their stories on video? Just a quick 1-minute clip talking about, just like he just said, what have the experiences been of people who felt marginalized within health services research? I was all gung-ho. I thought the idea was wonderful. The challenge that I did not anticipate, and this is being very transparent, was that people would not want to do that on video. It never occurred to me that people would not want to share those stories on video. And I think part of it was, as I think about it, I myself have had some real significant challenges. And so if I get on camera and say that, and that floats around somewhere, I've worked at 3 institutions. It's not hard to figure out which one of those institutions I'm talking about and what are the long-term negative ramifications for my career if people find out I'm speaking truth, but they didn't realize how structurally racist those academic institutions were. So that was enlightening for me, and it, really made me have to take a step back. And so for us, that was one of the challenges, just figuring out how do we collect this data in a way that's not re-traumatizing people. Some of these stories are difficult that people have experienced, and it was long-term difficult. It wasn't just a snapshot in time. And so that was one of the positive things that came out of our work, but also one of the challenges that I feel like we're still trying to work through.
Yeah, that's a great example. Pierre, do you want to pick it up and tell us a little bit more about your experiences using this method?
Sure. I was introduced to it by an incoming doctoral student in the RPH program who asked me the very frank question, why don't we use human design more in our work? And once I learned more about what it was, it made perfect sense. That was 5, 6 years ago. And since then, I have made use of this methodology several times, but included in that, those sort of iterations have been an attempt to bring it into a School of Public Health curriculum and sort of operational dialogue. And it was interesting because the School of Engineering and the School of Business were willing to seat a course with human-centered design in it, which was taken by many public health students, but the course wasn't seated at the School of Public Health for various reasons. And it was interesting to me, though, that the School of Engineering and the School of Business were willing to seat it in their schools far more nimbly and quickly and in a much more timely manner. And I think that that says a lot to me about the speed with which public health can sometimes move, or the lack of speed with respect to which public health can sometimes move, and how new, different, sometimes product-oriented, businessy things may seem to be uncomfortable to us, and we shy away from them. The funny thing is now I have colleagues talking to me about how many of the RFPs they're looking at now are calling for human-centered design skills, skills that we still don't teach in most schools of public health. So I thought it was brilliant that Academy Health and Robert Wood Johnson Foundation saw fit to use this method to expose people who hadn't been exposed to it before, and hopefully bring some of them into the fold with respect to using it, not exclusively, but being aware of it and appreciating it for what it is, because it has significant value for some of the reasons I've already stated, but especially because we in public health probably could do with a few different tools in the toolkit, especially given where we are right now with this light being shown on so many different things.
Great. Well said. Andy, do you want to add anything here, or even talk about some of the drawbacks that you might see to using human-centered design?
Sure. Yeah. Like my fellow panelists, I mean, this was a pretty new approach to me, and I had sort of a vague notion of it, but I was kind of skeptical, I must say, when it was first talked about, is that this would be the approach. I mean, it definitely has. It takes you out of your comfort zone, as was alluded to. Whether it's doing art projects or playing other kinds of mental games to sort of like make you aware of some of your thinking biases and so forth. I mean, there was no question that at times it felt either a little redundant or unclear where we're going. I will say in support of the method, which definitely has won me over, that it did something very different than a lot of expert type panels I've been on. I mean, in one way, it sort of stripped all of us from having to self-identify as any kind of expert. And I think the process ends up feeling quite democratic, very bottom up, by focusing on the process allows ideas to percolate up. And I came to really enjoy the interactions in my small group, and just being able to share and bounce ideas. It definitely was less hierarchical feeling than many other expert panels I've been on. If I was to identify something that was a bit of a drawback and is a challenge, we are, there's about 100 of us doing it. We're all pretty busy people spread out all over the country. We're not able to spend physical time together. Even before COVID-19, there were limitations on how often we could get together. We've tried to, of course, supplement that through video chats and things like that. But nonetheless, people are busy. And I would say that fundamentally, human-centered work kind of is the equivalent of like a team sport. And so maybe like those who exercise as adults and notice, gee, I loved playing team sports when I was in school, but they aren't so practical as an adult because sometimes you might get to the basketball court or the baseball field or whatever and find you don't have enough members of the team to kind of move forward. So I would say in some cases, even when there was tremendous enthusiasm, when all the team was together, and it was really a special feeling to build ideas together, it is challenging, I think, to sustain to some extent because of just trying to have very busy people and kind of the need for it to really work by having a sustained commitment and involvement of the group. Having said that, I would still say much more positive to say about it than negative, but I think that is a challenge.
Yeah, that's a great observation. I think it speaks to why we've narrowed the project to really focus on these areas that are of such urgency right now, because it does take a lot to pull people together. I turn to Alfie and Pierre. Any drawbacks that you see that we may or may not have overcome in our learning curve here?
Go ahead, Dr. Alfie. I cede to you.
I think the only I would say is thinking about what my experience has been as the air quotes, I'm saying this with air quotes, traditional health services researcher, is that a potential, it's not to say that it'll happen, a potential drawback was echoed by both my colleagues, which is once you come up with a design and once you create a path forward, the likelihood that our traditional sort of research colleagues in health services research will be able to get on board. I think that is a concern, and that was certainly a concern that came up in my group, because we do know in our field what the trajectory is, right? I'm a mental health services researcher specifically, and so, I heard I think it was either Dr. Benman or Dr. Pierre say earlier about the origins of our field, right? So it's biomedical research, is, in mental health services, it's a lot of stats, right? So medical anthropologists, those are the people that I've encountered, right? Health economists, these are all the kinds of folks, and big epidemiology. And thinking through how do we take human-centered design and overlay that with all of these traditional forms or traditional fields that really form the basis of health services research. So I think if anything, that's the only worry. I try not. I have to work hard not to worry. I try not to worry, but it's just once we have these prototypes, once we come up with these designs, once we have these brilliant ideas and we have them crystallized and turned into something actionable, how do we disseminate that, right? That's another part of our field, dissemination and implementation. How do we get that and spread it out into the field in a way that makes all of that good human-centered design, makes good use of it? So if anything, that's something that I heard quite frequently, and quite frankly, is something that I do think we want to be mindful of and try to work through.
So that's a great observation, and leads us to, I think, what I want to make is maybe our last question. I've been impressed that human-centered design creates very creative solutions, sometimes surprising, and in their creativity. And yet we really want, as you've said, Alfie, for this project to change the field, to really make it more timely, more relevant, help us be those active participants in problem solving for improving healthcare and making it more equitable. And so what do you all think will be necessary in order to achieve that outcome, to actually have this project change the field in a substantial and positive way? I'll let whoever wants to take that first jump on it.
I'll just throw this in there, and it actually relates to this question and the previous one to some extent, because I think that we all would do well to become more comfortable with being uncomfortable. And I think that is difficult, right? It sounds like an oxymoron. Why would anyone want to become comfortable with discomfort? Well, this process is not a comfortable process. There was definitely some almost physical reactions that people were having to being asked to do things a particular way within this process. And I've seen those same things as we go through this. I use this every semester with students in a very short design sprint. And there are members of teams that do not like this process because it uncovers elements of things that they're not necessarily willing to share within the setting of a team doing a project. But I think that if we really get down to it and we get past that and we get comfortable with being uncomfortable, then to your point, what we can create with users and with each other far exceeds our wildest imagination, or because we broke through. And I think that that may sound very namaste-ish to people. It may sound very sort of like, oh, that's pie in the sky stuff. But, you know, there's good data out there, quantitative data, about how well diverse teams do relative to homogeneous teams, and how creative those teams are in putting things out there that actually are sustainable ways of changing things and changing outcomes, that teams that do the same thing the same way don't necessarily get to. So that's my hope, is that we can get through this discomfort, and that will help us in so many different areas of all of our lives, individually and professionally and civically.
Terrific. Alfie?
My thought was just to say that all of what Dr. Pierre was describing, it excites me. I was on the phone, I'll say earlier this week, with a colleague, and the colleague was describing some research to me, and it was very traditional, and they named some of the same names that I remember working with when I was a postdoc, literally 20 years ago, and they were describing the research in the same way, and I frankly found myself yawning. I just thought, wow, are we still here? You know, is this where we still are? And so the thing about what we're doing is that it gives me life, right? Thinking about new and creative ways to reach people. Thinking about, you know, I used to think photo voice when I first got out of graduate school. Photo voice was like, oh my God, what is that hokey stuff? But now, like, I understand, right? Because you really are trying to capture people's lived experience, and that is critical. You cannot create something that's going to be useful to any of us if you don't fully understand the depths and the breadth of people's lived experience. And that includes us as academics or researchers, or whatever title we want to go with, or human services engineers, or health services engineers. And so for me, it's the excitement and it's the freedom, right? So moving to a space where I was a traditional academic and now run a foundation that I created, I love this idea of how do we think outside the box and create something different. Because for our young people, I'm a child and adolescent person. I don't know that they're going to be able to engage with us if we don't figure out how to extend the olive branch to them. And I don't think the olive branch nowadays is the traditional way of doing things. We've got to be creative. So to my colleague's point, as he just spoke, you know, it makes me think there was a time when, you know, in my lifetime, I don't know that I ever would have heard people talking about structural racism openly, structural discrimination openly, and acknowledging and naming it. Like all these organizations out here giving support to organizations that want to support the mental health of people of color. Again, going back to my experience, that's phenomenal. And so to me, that means there's hope. And so there's an opportunity through what a huge organization like AcademyHealth is doing. If they can get on board with human-centered design, I think anybody can get on board. So that's my hope, is that it's fresh, it's new, it's innovative, and it can really move us out of these sort of traditional, dare I say, sometimes stale ways of thinking and doing things.
Absolutely. Andy.
Yeah, well, this is, I really appreciate hearing from my colleagues on this panel. I think they're exactly in the right place. You know, as I think about where our field is going, you know, I think there will be, I think Alfie just mentioned it, that we need to think about different roles, different kinds of questions for the field to focus on. I think there will continue to be a need for, and there will be great value for, a small portion of our field that is focused on innovating in the methods, making, you know, how do we make use of the new kinds of data that are coming along, where, you know, of course, the amounts of data have never been greater in our field, whether that's from electronic health records or other kinds of big data and so forth. The availability of new kinds of tools through machine learning and so forth is always going to provide opportunities for learning new methods. But in my mind, that should be a small portion of what perhaps our field should be focused on, and more people focused on some of these really applied questions. I think that's what excites many of the people, the young people coming into our fields. How do they improve the systems of care where they provide care? How do they improve care in their community? These really significant questions that I think people enter into the field but then feel frustrated. And why do they end up feeling frustrated? Well, because the funding is not aligned in a way that supports those kinds of investigations. The promotions process is not aligned in a way that rewards impact so much as it rewards, did you get a grant, did you get a paper published? And I think that really speaks to where we have to look at some of the kinds of incentives that we have perhaps borrowed from other fields and have decided that those are the metrics to apply to our own field. And it's not to say they need to be thrown out 100%, but I think we have not sufficiently created the metrics of impact and developed ways of making sure that we are disseminating knowledge in a way that's much more actionable and not unique to a specific circumstance. And I think if we just listen to what excites our trainees and give them a chance to take on the big questions and not try to shape them in the direction of what the field has been. Like you said, Alfie, if the same person from 20 years ago is still trying to do the same kinds of questions, we're not making the advances that we need to do. And I also think our field needs to really take a hard stand of deciding what is it that we are trying to solve together. It's much easier in these narrower clinical fields to say, we are trying to eliminate heart disease, or we are trying to eliminate autoimmune disease, you name it. The NIH institutes are aligned that way. I think as a field, we need to decide what we are committed to as a group and that we want to fix, and hold up that mirror to ourselves all the time to see if we are making progress along that path, because that's what we need to do. And I think the greatest challenge before us today has really been highlighted so well by my colleagues, that we have an inequitable healthcare system, we have tremendous disparities. This is an area in which we need to develop really shared metrics of what progress would look like, develop tools to make progress, and hold ourselves accountable to making a difference in that way. There is no problem bigger in our society today than addressing that, and we should be out in front and leading that. And I think that is the kind of question, and big and important question, that will attract people to our field, and that we need to be ready to take up that challenge.
Yeah, well, I think this has been an incredibly rich discussion, and the points that have been made, I think, just underscore why the Paradigm Project is critical at this juncture in the history of our country, and the history of the world, and the history of our field. And when we started it, we felt that the disruptions that we were all experiencing were going to make the project infinitely more difficult to accomplish. But as it's progressed, I think that what we've learned, and what all of you have pointed out as we've had this discussion, is that we have a tremendous opportunity, an urgent opportunity, to show that we can change our field in a way that can have an immediate impact, and where we can see it and get inspired by that, and develop a platform for extending that even broader. So I think that this opportunity is going to be one that I hope everyone joins in, as Sherry said, that people react, join the reactor panel, move forward with some of the actions that we can take coming out of this, because I really do think we're going to look back and see that this was a critical moment in changing the way we do our work and the way we improve healthcare and health equity in this country. So with that, let me close and thank our panelists, Alfie, Andy, and Pierre. Thank you.